Hi, I'm Dr. Epling, and this is Evidence-Based Medicine. We're going to talk today about studies about diagnostic tests. Diagnostic tests studies are sometimes a little bit confusing for students because they tend to revert to the old randomization, blinding, withdrawal, sort of critical appraisal methods. The study of diagnostic tests is completely different, so pay attention to the validity criteria here and really think about what these diagnostic tests are really trying to tell you. What we're basically trying to do is compare a test of interest, some new test that we've developed, to the reference standard, or the gold standard test, the thing that we use to definitively say that somebody has a disease. The outcome in this, if you're doing the PICO questions, patient intervention comparison outcome, they look a little bit different for diagnostic tests. In this case, it's patients. The intervention is the test of interest. The comparator is the gold standard or reference standard. And the outcome is just the diagnosis of the disease. And it's not, so when you're asking this question and trying to figure out what the study actually talks about, the study is looking at the diagnosis of the disease, and that's all. There are other studies out there to assess the usefulness of diagnostic tests. For an example, with beta-natriuretic peptide, which is used in congestive heart failure diagnosis, the initial studies talked about the accuracy of BNP to determine whether somebody had congestive heart failure. But the later studies looked at the inclusion of BNP as a diagnostic test in the overall management scheme for patients presenting to the ED with shortness of breath. So here they're using a diagnostic test as an intervention. Did it actually change how these people did to do this diagnostic test on somebody? It's kind of the next level of what you really want to know for a diagnostic test. In this case, however, for this talk, we're just talking about, does the test actually accurately diagnose the disease, and to what extent do the results give us the test characteristics, sensitivity, specificity, predictive values, and likelihood ratios that we use to understand how well a test works. The study designs are important in this. It's not a randomized controlled trial for these type of studies. It's just a cohort study or a case control study where you're basically doing observational data. You're observing the whole group, because everybody's ideally getting the same things, and you're figuring out whether or not the test predicts the result on the gold standard. So validity. Remember, for validity, this is a case control or a cohort design. You can do them either way. Case control designs are a little harder because you have to hope that what you're doing is finding people with the different diagnoses and looking back in their record history or whatever to determine if they had the tests of interest. So that's a bit unreliable, right? So certain patients with a diagnosis may not have had the specific test that you're looking for. So the best way to do this is in a cohort study, a prospective cohort, where you enroll people that have a possibility for a given diagnosis, and you do both the test and the reference standard on everybody, and then compare those down the road. So the one-sentence validity is kind of a run-on sentence here, but the one-sentence validity assessment is this: is there an independent blind comparison to a recognized reference standard for the condition in an appropriate spectrum of patients? So let's break that down a little bit. What's the reference standard? The reference standard should be the overall, the best way to the most definitive way to diagnose the condition. This is often pathology results like autopsy or histology or lab results, something like that. But for other diseases like psychological diseases and other diseases, it's kind of hard to determine what the gold standard is. Gold standard for depression, for instance, might be a structured interview by a psychiatrist, and that may be the best gold standard you have for determination of the condition. So you have to give some thought to whether the thing they used to tell whether somebody had the disease was in fact the best way that they could diagnose the disease. What you're doing with the validity or with the diagnostic test studies is comparing the test of interest to that reference standard. So that comparison needs to be independent. In other words, everybody needs to get the test and the reference standard. The application of the reference standard cannot depend upon the result of the test of interest. So how would this work? Well, if you're doing fecal occult blood tests looking for cancer, and the gold standard might be a colonoscopy with biopsy, that's the gold standard for diagnosing colon cancer in somebody. The determination of who gets that colonoscopy cannot depend on the FOBT result, the fecal occult blood test result. There have been studies in the colonoscopy literature, or the colon cancer screening literature, of where people with a positive FOBT went and had a colonoscopy. People with a negative FOBT just got followed for several years to make sure they didn't basically end up having colon cancer. This is okay if you have to do it, but it's not the best way to do a diagnostic test study. Ideally, in that sort of scenario, everybody would get a fecal occult blood test, and then everybody would get a colonoscopy, and then you could compare the results well. The blind comparison means that the people doing, the researchers doing the first test, the test of interest, can't be the same ones doing the gold standard test. They can't, and they can't know the results of each test. So if I'm comparing my physical exam for splenomegaly, for instance, and I compare that with an ultrasound that can measure the spleen and tell me whether it's splenomegaly or not, I shouldn't do the exam and then pick up the ultrasound probe and do the ultrasound. That's potentially a biased result. I might think that I found a spleen, and so I might measure that spleen a little bit larger than it actually is. So two separate people should be doing these results, and they should be blind to the result. They should be doing these tests, and they should be blind to the results of the other's test. An appropriate spectrum of patients just means that you want patients from a variety of different conditions and settings to study, still with concern for that disease. So if you're studying chest pain, for instance, you want old and young people and hospital and outpatient settings, get the real variety of how chest pain presents. If it's and the problem, the real effect of this is, one, some of the statistics can vary with different presentations of illness, but two, it's a generalizability concern also, that you may not be testing on the right patients, and so you can't apply this test to patients with a different set of characteristics. Other considerations when you're recruiting for a diagnostic test study, you want to do either consecutive recruitment or random sampling. So if you're doing an emergency room study on pulmonary embolus, for instance, you want to take everybody with a little bit of chest pain and shortness of breath, people that in whom you consider the diagnosis of pulmonary embolus, and you want to invite all of those people just consecutively 24 hours a day, 7 days a week to your study. If you're the only one doing the research and you're only doing research during your shifts, and maybe you happen to have the day shift, you might not get a good spectrum of patients coming into your emergency room to test, and so your results might be biased that way. Random sampling might be sampling from a big population, and you just pull people in at random that might have this diagnosis and include them in the study. So either consecutive or random sampling, not convenient sampling, which would be the bad way to do the sampling. So for results, diagnostic test studies produce results called test characteristics: the sensitivity, specificity, positive, negative predictive value, likelihood ratios for a positive test and a negative test, an area under the curve determination from a receiver operating characteristic curve. There are all sorts of test characteristics that we can look at. Remember that sensitivity and specificity do not change with prevalence. That should be something drilled into your mind. And that means that we can't rely as much on predictive values to be able to understand this. Why is this all important? Well, sensitivity and specificity don't do the best job of having us understand how to use the test as clinicians. Because sensitivity and specificity, if you picture the 2x2 table, you already know which category they're in. They either have the disease or not, and you're just trying to figure out if, for sensitivity, if the patient has the disease, does the test actually label that patient correctly? And similarly for specificity, you take a bunch of people you know don't have the disease and you test them, and you're hoping that most of them come out test negative. Well, that's not the way clinicians work, right? Clinicians work by doing a test and then figuring out if that means that the patient has the disease or not. That's how we want to be able to use these tests. So we have to go, if you can picture it, sideways or horizontally on the 2x2 table, and figure out, given a given test characteristic, or given a test result rather, does that mean the patient has the disease? And hopefully it does, or doesn't, depending on the predictive value. Likelihood ratios help us do that. So predictive values are too dependent on prevalence. They change given the prevalence of the disease in different groups. So we need to calculate something called likelihood ratios. We go through all this stuff in another presentation on the calculations for these things, so I won't go over that tremendously here. But I would expect everybody to be able to calculate likelihood ratios and get a real sense of how they're used, and we'll go over that in a little bit in a second. Actually, we'll go over it now. So this is called a Fagan nomogram, and the utility of likelihood ratios are the following. Every patient, you can see the cursor here, every patient has a pretest probability, a likelihood that they have the disease before you test them. And in this case, it's 50%. You're about 50% likely to have the disease. In this case, it's around 25%. In this case, 75%. The likelihood ratio that you calculate, which is a calculation from sensitivity and specificity, will give you a likelihood ratio if it's a positive test and a likelihood ratio for a negative test. So say the test is positive, the likelihood ratio for that test, for a positive test here, is about 4. So if you take the patient's pretest probability and a likelihood ratio of 4, you get a post-test probability. Now, why this graph? Why don't we just multiply something? Well, it turns out that this whole scheme is based on odds, and we have a hard time thinking in odds. We like to think in probabilities. So what you actually have to do is convert these pretest probabilities, percentages, to odds, multiply the odds times the likelihood ratio, get post-test odds, and convert those back to percentages again so you can understand them. Well, so this nomogram does that for you. It's like a slide rule. It takes the pretest probability and the post-test probability and allows you to figure out the effect of that diagnostic test without having to do all those calculations. So here we have in fairly low pretest probability, I'm not terribly concerned the patient has this disease, a likelihood ratio of 4, and we have that same likelihood ratio for positive tests in all examples. You see that it takes our estimation from 25% to 55%. So it pretty well increases our likelihood of the patient having the disease. And for a likelihood ratio of 0.2, it reduces the chance the patient has the disease down to the single digits. So that's a pretty good test. It helps us, probably sends us above a threshold or below a threshold on either side. For patients in the middle of, we're not sure whether the patient has the disease or not, it really does change the overall, a positive test does change the overall likelihood from 50% to about 80%. It narrows, a negative test would decrease the likelihood, but if it's a real serious disease, I wouldn't necessarily rule it out based on this. It doesn't decrease the likelihood that much, only to about 18%. For somebody that's really likely to have the disease, a positive likelihood ratio with a positive test increases your likelihood to have the disease, but what's the impact of that? You're already 75% sure, now you're 92% sure. It doesn't really change your management that much. You're already pretty sure the patient has the disease. What it can do, a likelihood ratio, and especially if you have likelihood ratios that are real low, like 0.2, 0.02, 0.01, it really drops your post-test probability. The patient goes from 75% likely to only about 38% likely. So this is how likelihood ratios are used and how these Fagan nomograms are used, which you'll see in the literature a little bit. Obviously, for a likelihood ratio for a negative test, you want lower and lower and lower after the decimal point here. And for positive likelihood ratios, you want higher and higher to help you out the most. This is a receiver operating characteristic curve. You will see this in studies that are exploring the best type of either the best type of diagnostic test and the best cutoff for a given diagnostic test to diagnose a condition. So what's happened here is that they're looking at PSA, prostate-specific antigen, and another form of that. Now, prostate-specific antigen is a continuous, it gives a number, which is a continuous variable, right? It could go from anywhere from 0 to 100, 200, whatever. And so what they look for with these receiver operating characteristics curves is at each point that they study, at each cutoff for PSA, they calculate sensitivity and specificity for the given disease. So they compare it to, say, a biopsy of the prostate. So here, they calculate sensitivity and specificity, and they plot sensitivity versus 1 minus specificity. Now, for those of you that have done the calculations tutorial, the video on that, you'll recognize that sensitivity over 1 plus specificity is a positive likelihood ratio. So this all interrelates. Here, that point between sensitivity and 1 minus specificity is here. They have another point here, one here, one here. And what this does, when you map it out over different cutoff values for the PSA, maybe the PSA was 1 here, 2 here, 3 here, 4 here, and on up, you get a sense of, and you can draw a curve between all those points. Similarly, for this other test, you get another curve, but the reference point is here. In other words, this means that the test is worthless. The test doesn't change your impression of whether the patient has the disease or not. What you want is, so this not only confirms that maybe this test is better than this test, but it also gives you the point at which you should cut off the test. In other words, what the best discriminatory cutoff is for PSA. They don't give the points here, but it's basically the point that's closest to this upper left-hand corner. So probably this cutoff right here, whatever that is the best balance between sensitivity and specificity for that given cutoff level. So ROC curves can do two things. They can give you a sense of which is the overall better test. The more area under the curve, all this area under the curve is measured at times. But it can also tell you what's the best cutoff value for that continuous variable test, like a PSA. For applicability, similar to randomized controlled trials and systematic reviews, you have to know if the test that you're looking at is available, if it's even available in your lab, if you can do the physical exam maneuver, you know how to do it well, those type of things. Is this test available and can you use it? Did the patient study resemble my patients? This is important if you're looking at, say, screening tests that were developed out of maybe a specialist's office, and so people that go to specialist's office generally have a higher prevalence of disease because of who's seen in a specialist's office. In a primary care physician's office, you would have a general cross-section of the population, so the test may not perform similarly in both of those places. So ideally, tests should be studied in the populations to which you intend to apply those tests. And ultimately, will the test change my management? We went over that with the Fagan nomograms. Usually, tests work, especially if they're okay but not great tests. They work best in the mid-ranges of pretest probability. So if I think the patient if I'm kind of undecided about whether the patient has the disease or not, I don't feel strongly one way or the other, then that's the time that the test can be most useful. Obviously, the counter to that is if you are pretty sure that the patient doesn't have the disease, or pretty sure that the patient does have the disease, pretest probabilities below 10%, for instance, or above 90%, then you really have to, consider what test you're doing and whether or not you need to have the definitive test applied rather than just the okay test. If the test isn't going to really change your likelihood of having the disease or not, then you don't have any reason to be able to apply that test. Also consider things like if you do tests on people with a low chance of disease, you're more likely to get false positives. If you do patients with a high risk of disease, you're more likely to get false negatives. So you have to bear those in mind when you're doing your decision making. So that's it for diagnostic tests. We'll see you next time.